Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. Well, welcome everyone. Hello and welcome to the February 2025 Pre-Hospital Care Research Forum Education Research Journal Club. The PCRF promotes research literacy to advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. A big thank you to Limmer Education for sponsoring these podcasts so we can bring you the best of science in education. I'm Megan Corey. I'm here with David Page and Michael Caduce, who's going to be also one of our guest authors, Dr. Kim McKenna and Dr. Bill Toon. Today, we have a great topic here and a great article that was published in the Western Journal of Emergency Medicine. It's entitled Perceptions and Use of Automated Hospital Outcome Data by EMS Providers, a Pilot Study. So thank you all for joining us today. And remember, if you miss anything today, if you have to take off, or if you want to visit some of our other podcasts, you can go to our YouTube channel at youtube.com/@PCRF@UCLA. And remember that you can subscribe. So if you miss something, come back. It's already there for you in your playlist. Remember to quote, tag, and share #EMS Research or on one of your favorite social media sites at PCRF@UCLA, and join us each month. This is a great topic that we have today. So I wanted to just bring in the authors. We have some heavy hitters here today. This is an all-star cast if you look at this article, which, by the way, is open access. And this is, again, Western Journal of Emergency Medicine. It's the November 2024 edition. The primary author here, Michael Caduce, is one of our regular panelists in all of our podcasts, our journal clubs. We also have Dr. Scott Bourne and Dr. Tony Fernandez. They're joining us today to carry us through this study. I want to really start by asking Michael, if you can just tell us, the why this topic. You've done a lot of different, you've dipped your toe or gone head first, whatever you want to say, into a lot of EMS research. Why this topic in particular, outcome data?
Well, thanks, Megan, and thrilled to be here. And there's a lot of heavy hitters on research. I'll put my name in the coattails of those that have published some great work, the likes of Scott and Tony and yourself and Kim and Dave and Bill. This topic was just a conversation of ideas at a conference where we had some folks sitting around a table saying, we think we have the capability to do this in terms of getting EMS providers the ability to see their outcomes, but no one's ever really looked at, do they want to see them? And I think if we did a poll of the people in the chat, do you care what happens to your patient after you drop them off at the hospital? We sort of intuitively know they probably do, but no one's really looked at it on a large scale before. And so the group of authors sitting around here said, we think we have the capability to actually start doing this and looking at it. And that sort of just led into the continued discussion about continued competency, offering some actual CE for it. So that's really what got us started. We just started with the conversation of, can we do this? And we really got to a point where we thought, like, yeah, we can.
You just said something and I kind of forgot to say it, but thanks everybody for joining us right now. If you please pop in the chat, this is a real important topic to a lot of people. And to what Michael just said, I just want to remind you, you can put your stuff in the chat. We can bring it into the conversation. But what a great first, little question there is, do you think that people think it's important? Do you think no matter what you do, if you're a primary educator in an initial pre-licensure, pre-certification training program, or if you are a continuing education, or both, do you think people, your providers or students find it essential or important to get outcomes data? Do you think they're interested in it to begin with? What a great question.
Yeah, and I certainly feel like as a paramedic, I was really interested in knowing what happened to my patients. The sort of difficulty is, right, a lot of agencies have sort of a makeshift way to get this data, right? Like you click a box in your EPCR and that sends an email to someone at the hospital who, if they have time on top of their other 120 duties, will send you a little bit of follow-up. It's not automated, which again makes it really, really difficult to get that information, where we could actually implement some bidirectional data exchange to do that. So I sort of thought to myself, like, gosh, I always would have liked that. And then ESO sort of has the ability to do it, but a little bit of the details and how we got there, and sort of a bit on the just like, hey, here's how we made it to our objective statement is like, um, again, we know that we sort of intuitively think providers want this information, but there has to be more than that, right? Just I'd love to not come to work every day and sit on the beach, but that's just not a real feasible way to do life. We wanted to look at like, okay, does getting outcomes actually drive performance metrics, right? Right now, every EMT and paramedic across the country has to do some sort of hour-based model to renew their certification. Though we've known since the 90s that that's been our model, but never truly demonstrated competency. And that sort of makes sense, right? I sit in the same opioid awareness class that every other paramedic sits in, but I may be really bad at it, or I may be really good at it. No one really connected those topics together, and to look at, does this generic hour model work? And again, the research sort of says it doesn't. So we looked outside of EMS and said, well, what do other providers do? And there's this concept of continued professional development, or CPD, that says really continuing education should be learner specific. So it should take what you do well and help improve that, and also take what you don't do well and improve that. And again, that's seen in graduate medical education. In fact, there's some national position papers from some national medical graduate programs that say like, your specific feedback during your residency program or your fellowship training, your med school, should be specific to you. It shouldn't just be this, every med school gets the medical student or resident gets the exact same information. Again, it also, this continued professional development concept says it should be user specific, patient centric, and it really aligns with bringing it back to EMS, the EMS Agenda 2050, which again says you should be able to know how your patient did because there should be a uniform medical record from start to finish. That concept is supported by CMS, the Centers for Medicare and Medicaid, and really supports this bidirectional data exchange that says like, okay, it is possible for you to find out what happened to your patient. It's not a HIPAA violation. And I think our hospital counterparts know that, and they do this, right? If you see the patient in the ER, you can go look up what their status was after the hospital because you did care for them. But somehow when we leave the hospital doors, we think like, HIPAA stops at the ambulance bay
Hmm.
doors, and we can't go back and look at that data when in fact we truly know that we can. So if we take that continued professional development concept and we apply it to EMS, and we find this user specific concept, which could possibly be some patient outcomes, and we find a system that does it, we start to see that there are some small studies that have looked at, do providers want to see their outcomes? Very few actually look at like, okay, what's the next step, which is, did it make them a better provider? To just sort of like, it made me happy that I knew that when I thought it was a stroke, it was a stroke. But we don't know if that makes you any better as a provider
Hmm.
that you knew that information. It also sort of forgoes a lot of patient follow-up where like, oh, it was a heart attack, I knew it was a heart attack, I don't care. Well, but maybe you should, because maybe it wasn't a heart attack, but if we're
Hmm.
confident in what we think it is, we'll never actually go look. So we really need this system that sort of automates it and does it for everybody, not just the patients who request it. Because to your point, it's usually the zebras, right? I have no idea what this is, but it's not the horses. It's one of the striped creatures that I can't identify. So we get feedback on that. But does that really drive clinical practice when most of our
Hmm.
calls are not zebras? So that really got us to this topic of saying like, okay, can we provide automated hospital outcome data to EMS providers and then ask them what they think of it? And maybe even ask them
Hmm.
what they think before we give it to them so that we know there's a concept here. And come to find out, Up to Date actually does this for CME. So if you're a physician and you read an article on
Ah.
Up to Date, you can get CME credit for it. So we said, well, maybe we can do the same thing for EMS. But before we go down that rabbit hole, we really need to know what EMS providers think. Do they want to see this information? Maybe it's just us in our silo thinking, of course they want to know their patient outcomes. We should probably ask them what they think.
Yeah.
And if we can give some CE credit along the way, even better. So that's where we got to a large scale to look at it. And that's where I answer any questions on the introduction and transition to the very brilliant Tony Fernandez, who's going to talk us through the methods and why we have this capability to connect hospital patient records with EMS patient records.
I was just going to say that the people that are listening are affirming that the need to do this. You know, Chris Liebedor is saying, yeah, how else are we going to know if our protocols are working if we don't know what our patient outcome is? And then Karen Jacobson pointed out the fact that it's always been hard and people always, you know, held up the HIPAA banner saying, oh, you can't share information. But now that we can, it's really important for the learning process.
Amen.
What a great point. So the system didn't exist before, and now the stars are aligning, is what we're saying here, right? So, Dr. Fernandez, come on in and tell us, how did you do this?
Well, I'd want to say thanks again for having us. I'm excited to be able to talk about this study. This was um, one of the more rewarding ones we got to do because, as we're seeing in the chat, this is so important to the providers who are out there really doing the work in the field. Excuse me. So at ESO, we had implemented our health data exchange, and this is a bidirectional sharing of data where EMS records they flow directly into the hospital EMR, and then the hospital clinical outcomes they get delivered to EMS in real time. So when you log on to your EHR, you can go into your outcomes and see if any of your patients have outcomes that you can look at and see, what did happen to the patient and were you correct in your assessments and the like. Um, Now, we knew that folks were using this, but we didn't know how beneficial it was to them, other than, like Michael Caduce was talking about earlier, just what we thought that it would be interesting for them and help their professional development and things like that. So what we did for this study was we worked with three really high-performing EMS agencies from around the country. And they volunteered to have their paramedics and EMTs as part of this study. So we were able to reach out to them. They did a little pre-work for us to let the providers know that this information was coming, this invitation was coming. And we sent them an invitation when they logged on to their EHR. So when they logged on, we said, hey, you have an opportunity to be part of this study. And all you have to do is look at your outcomes, answer some questions, and you can also get CE for being part of the study. So as you can see here in table one, these were the providers that participated. We had a pre-study and a post-study. One thing to note about these agencies, and this is in every study, you'll have some kind of hindsight. How could things have been done better? In all of these agencies, they were provided 100% of their continuing education through the agencies. And one of our carrots was that we're going to provide you continuing ed. So this may not have been the right carrot for these groups since they got it all already. But you'll see we still had some pretty fantastic participation. So we sent the survey out to about 840 some paramedics and EMTs that worked among these three agencies. And as soon as they logged on, they had an opportunity to participate. In order to participate, we asked them to fill out the pre-survey. And in the pre-survey, we asked them things like, have you ever used HDE before? How valuable do you think HDE is in terms of your professional development, in terms of becoming a better clinician, in terms of your growth and your satisfaction in your job? And we wanted them to then go in, run some cases, and look at their outcomes. And for the outcomes, because we were giving them CAPC credits, they did have to answer some questions and watch some videos related to these outcomes. So one, we wanted them, the outcomes often are delivered in ICD-10 codes. And we do give the descriptions, but we wanted folks to really understand what ICD-10 codes were. So they had to watch a short video about what ICD-10 codes are, and they also had to watch a short, which was just the most interesting video you could watch. Let me tell you. they also had to watch a video about understanding the Centers for Medicaid and Medicare disposition. So what does it mean? What does it really mean if a patient is transferred, or if they're obviously we understand discharge and the like, but what if they transfer to a SNF or a skilled nursing facility, those sorts of things. So they had to watch the two videos. Then they went in and answered. Then they went in and reviewed their outcomes, and then they answered some questions about the outcomes that they reviewed. Once we left that open for the study period, and then towards the end of the study period, we asked them the same questions again, and we wanted to see, did their level of satisfaction, did it increase, did it decrease, did it stay the same over the study period? So it was a really interesting study, and we were able to get some really good engagement. We had about 200 folks either complete. Apologies for the dogs in the background. We had about 200 folks complete the pre and the post survey. The numbers were pretty close. And we were able to dive in and find some really interesting things. I don't want to steal Dr. Bourne's thunder when we talk about the methods. I'm sorry, the results. But one of the really interesting things that we were able to do above and beyond just the survey results was we had a world-renowned expert in qualitative methods, Dr. Scott Bourne, put together, went into some of these qualitative, open-ended questions that we were able to ask and really teased out some really important information. So I'm really excited to talk about that on the podcast today.
Great. And Dr. Bourne, you could
I'm guessing
jump
that's
right
my cue.
in.
I'm guessing
Yeah.
that's my cue.
And actually, I'm not sure if this is, so one of the things I wanted to point out too is here in that first table that Dr. Fernandez was going through, we have the role within the organization, which I thought was interesting too, just so you can see that who has direct patient care, who's a first line supervisor, I'm assuming has direct patient care in a different capacity, and then who are the others so that we know, the spread of the different providers. So that
Well,
was
and
an
Megan,
important one. Mhm.
Megan, I'm glad you went back to table one, because there are some interesting things that we teased out downstream, both in the qualitative analysis and, quite honestly, in the quantitative analysis that Tony did. Not only looking at what their role was, but the years of experience. It turns out that feedback data means different things to different people
Yeah.
based on their years of experience, which is a useful thing if we're going to plot someone's professional development over time. And it was interesting looking down at the bottom of this, how often people looked at the outcomes, and there were a substantial number of people that didn't do it very often.
Yeah.
So maybe it's because they don't have time, maybe it's because they don't care. Either way. So if you wouldn't mind going into that next table again, Megan. The questions that you see on the left side there were questions that Tony and Michael and I came up with as the things that we wanted to ask participants. And these are fine questions. I've zero concerns about these questions, but I'm going to guess all of you have answered a survey at some point in your life where the choices they give you, choice A, choice B, choice C, and choice D, when you were done, you kind of shook your head and said, I guess I'll pick C because it's the closest to what I think, but really none of those answers are right. And that, plus understanding the whys behind these questions, is the role for qualitative data. And qualitative data, number one, the name kind of tips you off. It's looking more at the qualities around responses and not the responses themselves. And oftentimes it helps us understand the meaning behind it. Tons of ways that we can gather qualitative data. The one that's the simplest to just kind of conceptualize is, I'm going to talk to people. I'm going to sit down with a paramedic and say, so do you ever get your feedback on patients? If so, what are you looking for when you go there? What do you learn? What did you find interesting? What really didn't help you any? That would be an example of qualitative data, and a qualitative researcher would probably tape that interaction to find that out. Qualitative data collection like that is really, really important for a lot of purposes, just in trying to really understand what's important to the people you're interested in, the frontline providers. Any of you that ever create surveys, it's a really good way to figure out what you should put in the surveys, rather than coming up with your own categories, to just ask people, what do you think you get out of this, in this case, getting patient outcomes, and then use that to develop your surveys. So I'll stop with the qualitative soapbox. It is not hard to do, but it's different than what's done in most research. And I was really grateful to have the chance to do it on this project. So what you're looking at here in table 2 is the quantitative data of answers to those questions. And there were then additional questions that you don't see on this table, and that's okay, that were open-ended questions, sort of the anything else we should know about this? And that was then my job. We took all that data from all of those individuals filling out the surveys, sent it to me, and my job was to review what people said. And it was usually a sentence or two. A couple people wrote the Dead Sea Scrolls, but most people, it was a couple words or a sentence or two. And the first thing that we do from a qualitative review perspective then is to try and identify keywords, that would help us understand the value that the provider placed on that information. And then take those keywords, and then you end up with maybe a list of 50 or 60 or 80 words, and try to then clump them into themes. From the themes, then we learn things. First of all, the themes would become questions that I'd put in another survey. But from the themes, we start to learn the whys behind these quantitative results. And so as we went through it, and Megan, do you have the first pass theme list?
I think it's table 4, Megan.
4? Yeah, there we go.
There we go, table 4. So again, before we got to this stage, I'd reviewed a couple hundred of these open-ended statements, gone through, looked at all the words, identified them. And I mean, you can do it as simply as with a piece of paper, and you're reading a survey, and then you say, oh, they just used the word affirming. So I'm gonna make that one of the words that I look at, and then go back and clump them. Qualitative researchers, also there's software that can help you do this that really makes it a lot simpler. So looking at number 4, the codes that I got, you see in the dominant codes pre-survey. So some of the things that I saw was, I like to do this because it improves my understanding of the patients I've seen. It furthers my clinical knowledge. You see me just working down that column. All of those were words or code words that I came up with from other words that they used that told us what they found as valuable in getting their outcomes. Then working to the left, you can see that I took all of those codes and started to pull them together into themes. And what you see at the far left there are the major themes that we saw, looking at the free text fields that people gave us. And I'll walk you through them because I think they were pretty important. And then I'll stop talking, and Megan can ask me more questions or let somebody else talk. One of the themes was, I like to get outcomes because I get new knowledge about patients, but also about medicine. I start learning that this symptom is associated with this disease. Something that really became interesting to me was it enhanced my personal confidence and competence. And we saw that especially in the younger clinicians. And then it became more affirming in the older clinicians. So I now feel more comfortable and confident when I say a patient's having an MI, that it's an MI, which then allows me to be more confident in my treatment plan. Improve my personal clinical practice. That's kind of a global, as I become a clinician, I get better. And as you can see from that key quote, and that's an important thing that qualitative folks do also, is identify a quote that really exemplifies the whole theme. So the key quote for improving my personal clinical practice, I review charts to QA myself for future patients. So that one's really looking in the future, where personal confidence is looking at this patient right now. Operations really was about prioritizing follow-ups and looking at resources that we need to include, whether it's new equipment or new protocols or procedures, and then support system-wide QI. So those really were the key themes that came out of those subjective free-text analyses that I got to do.
And all the while you're doing this, are you, when you did the pre-survey, you did that in isolation, and then you did the post-survey later? Did you do it temporally? You know, I do the pre-survey, and then later the post-survey results come out, or the post,
Yes.
you know, yeah.
Yes.
So they don't interfere with one another.
Correct. And it also could have had an iterative, we chose not to do this, but it could have also had an iterative impact, that the pre-survey might have influenced the questions we asked in the post-survey.
I'm
Now, in
so
this
glad
case,
you
we
used
didn't
that
do that.
word. Yeah,
Yeah.
I'm glad you used that word, because that is the word I think of when I think of qualitative research, and iterative. It is
Yeah.
iterative. And it also, not only when you're doing an isolated research project like this, but when you're building onto the next steps. Qualitative research is sort of this never-ending process of building on the next, level. So yeah,
Absolutely
this is,
true.
yeah. Yeah.
And the process itself was iterative. You can't see it here. I mentioned it in the discussion, but the themes that you're looking at here on table 4, this was the second iteration of the themes. The
Mhm.
first ones were much more process oriented, much more task oriented, I should say. Then as I looked at them, I saw there's really processes in here. And so those task themes iterated into the themes that you see here that are really process growth and future oriented in many cases. So
Yeah.
yeah, qualitative research is very iterative.
Mhm. Michael.
And actually, the next figure shows what Dr. Bourne is speaking about right now, which is the change from the pre-survey to the post-survey, and how we in the blue saw this pre-survey, and in the red the post-survey. We did see this sort of shift from acquire personal knowledge, which was number 1 in the pre-survey, and I think was number 4, the last category in
Right.
the post-survey. So we saw this shift from enhancing personal confidence and competence, which again was sort of the goal in all of this. Where I was like, I don't just care to know the random stuff, but like it actually helps me get better at my job, and a little bit of operational shift. And I think you had mentioned this, Megan, on table 1, where we saw some folks that were operationally oriented. They were frontline supervisors, or they were the CQI person. There's probably some of that coming through here. I didn't want to say that that's exactly what it is, because we can't say that for certain, but there probably some likelihood that there's some frontline supervisors like, I recognize there's some opportunities for some of my folks to gain some clinical knowledge, or to send them to a class or something like that. So I think there's probably some of those sub themes that we don't necessarily be able to tease out, but we can probably say, based on who took the survey, in the, where we saw the shift from the pre to the post, that there's something there.
Well, and you teed that up beautifully for me, Michael, because I think one of the things that we thought about a lot, and this may be intuitive to all of you, but what's it mean pre-survey to post-survey? Pre-survey means, here's what I think I'll do with outcomes. And so looking at this graph as a perfect example, I think I'm going to learn some stuff. Me personally, I'm going to learn some stuff that I'll want to know. That's cool. And so on. The post-survey was, here's the things that I think are most important now that I've had the outcomes. And I was fascinated. And in fact, I remember the call clearly when I called Michael and Tony and said, guess what we learned? confidence is now the most important thing that they get out of having outcomes. Well, that wasn't ever even on the questionnaire before. We didn't ask, did this make you feel, we asked if it made you feel smarter, but we didn't ask if it made you feel more confident. And so that's the other thing to think about when you do qualitative survey is your qualitative work is what's the before and after. Oftentimes in medical studies, it's we did treatment A at the beginning and now we're doing treatment B. In this case, it was I now have experience with something I didn't have before. How did that change my understanding of its value? And then the operations piece is pretty important. I've been looking at some of the comments that are coming in the chat. Chris Leibador started a discussion a few minutes ago about how we have to use outcomes in order to change protocols and overall care guidelines. And that's super important, not necessarily, I don't think, to frontline providers, but as clinical leaders and operational leaders, we usually build our care guidelines and protocols based on literature, what we used to do at the last place I worked, those kinds of things. And outcomes can now really help us understand that therapy doesn't seem to work very well. So let's try something different. This is not surprisingly my favorite figure in the whole paper. I'll stop talking.
Scott took it to the next level too, when we looked at the data analysis here, and this is what's in the supplement, because we just had a ton of data to extrapolate out, and they wouldn't let us put it all in the paper. If you look at the people that have 0 to 4 years of experience, you don't see quite as wide of this shift from personal knowledge to confidence and competence. The farther you go out, those that have 11 to 20 years of experience, or those that have more than 20 years of experience, this is where we saw a huge shift. In fact, it's pretty close, but I think we can reasonably say most folks, the majority of folks, saw this shift in that group of folks. So there's got to be something here too for the Dunning-Kruger effect of you're at the top of your most confidence and least knowledgeable, but as you sort of slide down that and back up the other side, you're starting to be more focused on gaining that confidence and competence. And as we talk continuing competency, that's sort of the goal, is to keep people in that focus. So I think there's something to that. I'll share the link for the supplement in the chat, but there's to me, it seems like as you look at the more experienced providers, the folks that we need to stay competent, there's much bigger of a shift in the outcome. So maybe it's because those folks also, because we had this conversation before we started, those folks also know what it's like not to have outcomes, where some of our newer folks have always had their outcomes to look at. And what a shift we may look to 10 years from now, when it's just like, well, of course I can see what happens to my patient. And some of us will sit around and talk about how, well, I remember the days when you just had to guess. All right, so there might be something there too in the years of experience where we're seeing less of a shift, but I think it's interesting to share nonetheless.
Yeah, well, and you bring up, Megan, do you want to ask a question first?
Oh, no, I was just going to say, can you talk when you're ready about the job satisfaction comment that you make too? It's right at the end of the results about, improving job satisfaction rose from 89 to 95% between pre and post surveys. And that was significant.
Yep. Tony,
especially
I'll let you
when
go.
we're talking about workforce all the time, retention and job satisfaction. I think that was such a powerful statement to make.
Yeah, and it's notable that was we hear a lot of issues about paramedic shortages and the like, and that was where we saw our biggest increase in job satisfaction was among the paramedics. And that was, while you can see as you peruse through some of these results, even at the start in the pre-survey, everyone was overwhelmingly supportive of the use of outcomes and looking at their clinical outcomes and how their patients did. But when you can tease out these little nuggets of how things changed, particularly for the paramedics, that was really interesting, because not only are they getting more confident, we found out that they believe that it does improve their clinical knowledge and it helps their job satisfaction. I mean, it's a win all across the board.
Well, and one other thing I'll comment about before we move forward, and that is, although I know we have to move forward, so maybe you just want to stay right where you are so I don't get stuck.
No, that's great. Go ahead.
But the other thing that we saw, and for all of us as education nerds, part of what we try to do in primary education is help people start to develop pattern recognition, that this kind of condition looks like this. And that explains why the novices, the number one thing they got out of that was acquiring personal knowledge, because they're trying to get those patterns locked in. So, so no, I think that's a great point. Tony, I'll let you walk us through here.
Yeah, I was just going to switch gears and say, let's look at the CE part of this, because well, if you give continuing education, then that will be, a motivating factor in this. And you actually tell us about what you found
Tell us-
about
Thanks so
this.
much.
Different than
So-
what we thought.
Well, again, and it's the right carrot for the right audience, right? We worked with three really big agencies who provided 100% of the needed CE to maintain certifications in all of these agencies. So providing the up to 8 hours of CE that they could get was not necessarily something they needed. So the fact that we still had folks go through and log on and watch the really exciting videos that I mentioned, and go through and actually collect this continuing education, I think that speaks to the fact that, yeah, it is important. It is a decent carrot. And I think we would have saw more uh, receipt of continuing education had folks actually needed it for their to maintain their certification. But you can see here, I'll walk you through this flow chart. So we had about 211 who said yes, they wanted to do the CE phase of the study. And then there were 78 of those who just never logged on to the on-demand learning. That's what ODL stands for in this flow chart, the on-demand learning part, to collect their CE. Now, in order to get CAPC credit, you have to complete a profile. So it's more work that you have to fill out. Unfortunately, we were not able to just check a box and say you get the CE. They had to fill out a profile and do some crossing their T's and dotting their I's to make sure we got them their continuing ed. So we lost some folks there in continuing the making the profile, and then the prerequisite videos. We lost about 34 folks there. So all in all, we ended up with 56 individuals who earned at least one continuing education credit. And then there were about a little more than half of those gained all of the credit that was available.
I think
So can you comment too on, don't you have to apply for CAPC approval before you can even offer CAPC credit? And then how, is this just like a standing relationship with CAPC that you have this, approval for review of outcomes
We
data?
actually, when we were coming up with this study, that was one of the things we did. We met with CAPC a few times. We told them that this was a pilot study. This is not something that's a standing, and this was a pilot study that we wanted to see if it worked. Would it work with these folks? Could we deliver the continuing education in this fashion? And to their credit, CAPC was on board. They were really excited about it, and they did everything they could to facilitate this study.
the specifics are for each outcome that the EMT or paramedic looked at, and then like hit the CE button and went and filled out their profile. They got 15 minutes of CE, and it was generic CE credit. So it wasn't specific to, like, it was a cardiac chest pain call. So it's a cardiac CE that gets a little bit more difficult to do, but Tony's exactly right. We really just met with CAPC and said, this is our goal. This is what we'd like to do. Sort of what credit would be appropriate to be awarded, as opposed to, like, we've dictated this. No one's done this before. So it was really just a conversation of, what do you think this would be best? But I was going to comment on just a little bit on the previous table too. Like, it seems like a lot of steps to go through to create a profile. And so I think bringing in some of the comments from the chat, if you are going to set this up and you are currently providing the CE, one of the things the study proved and that we learned is you can't make it overtly step-based. Like, it seems kind of complicated right now. It really isn't. If you've set up a national register profile, it's very similar information, but it does require you to go get your expiration date, right? It goes and requires you to get your NREMT number, your state number, and your state expiration date. I think we sort of intuitively know that that's that, but if your barrier to do that is so low because you don't need it, that's where we lost people. So the folks in the chat that were talking about, like, how do you do this? That would be one of the takeaways that we discovered, is like, you need to find a way to make that part fairly easy, or some requirement that they need this CE for some reason. They're clearly looking at it. Just the barrier to get this CE is what we found had some lacking. So this, based on what we found for future development.
As I'm interpreting what I'm reading in the chat, it's more getting the feedback from the hospitals in a bi-directional way. Folks are trying to set up that bi-directional communication, and the hospitals don't want to play. I don't know if you all have any advice for them having set up an HDE. What causes a hospital to really want to buy in?
Well, I think that more and more hospitals are recognizing, and there's to their point, some of the points that are made in the chat room, the folks that are in the emergency department, they certainly are interested in what happened in the field, what happened in the pre-hospital portion of this patient care. I don't want to turn this into a sales pitch for HDO, ESO, HDE, but I will say that there are benefits to using HDE, and there's a cost to it, but some of that cost can be alleviated when they work with their EMS system. So I would suggest folks who are interested in using this bidirectional data exchange to talk to their chiefs, talk to their hospital administrators, and there's plenty of folks at ESO who would be very willing to help facilitate this exchange.
Well, and I appreciate Tony's caution in not making this an advertisement. Having worked with some bidirectional data exchanges in some other communities, hospitals, there's an IT cost that's involved, and the chat's mentioned that, but logistically, there's two things in hospitals that they may find useful in a bidirectional exchange of whatever brand. One of them is they get information that may help them with billing that they didn't have access to in the hospital. And that's pretty important to most hospitals. And then the other is anybody that has a registry, whether it's a trauma registry or a STEMI registry or a stroke registry or a sepsis registry, the bidirectional data exchange oftentimes provides the registrar with information they need to submit to the American College of Surgeons or whoever the registry is with, that before they had to call on the phone and get the information from EMS. And so I think those two benefits in a lot of hospitals help offset their concerns about the IT cost. But this doesn't work if the hospitals aren't willing to share the data, and we all have to work on finding ways to encourage them.
And this research is a good part of that. I think that's the importance of having the research to then be able to feed to the EMS systems, who can then feed to the hospitals and say, look, this is, we're seeing some value. Also, like we said, the workforce issue, when we talk about retention and attrition in the workforce, and you can see an increase in job satisfaction if people have that's significant for EMS as well. So Tony, I'm wondering if you can walk us through these. I love this table. I think this table is really interesting for a couple of reasons. One is, after you stare at it for a while, this is the continuing education reviews, questions and responses, and so you can see, how people responded about how they used the data after they participated in the health data exchange. And one of the things I always think of is, did that strongly disagree person confuse the numbers, or who would strongly disagree?
There's always one, right, in every
Yeah.
group, and in some of these cases, I guess there were 2 or 5. But
Sometimes
yeah,
you see a confusion though between the numbers, and you see their comments are like glowing, and yet they have the scale flipped. They've misread it or
absolutely.
something. So
Yeah, absolutely. It could be that. And a lot of times folks are doing this while they're on the ambulance, and then they get a call. So that's certainly understandable. But even with the handful of folks who strongly disagreed on some of them, some of these results are fascinating, overwhelmingly support continuing education. Why did they do the continuing education reviews? You can see there's kind of an equal distribution between the goals of the reviews, between uh, getting credit for their renewal. Again, these folks didn't need this credit, but still, almost a quarter of them were going into the Con Ed portion to get credit for their renewal, increasing their knowledge and clinical conditions of the patient. But the 26%, they wanted to know if their assessments were appropriate, which I found encouraging, and whether their field impression signs relate to the hospital diagnosis, and that's the crux of why having a hospital data exchange will be important, right? I thought that what was really informative here was that there were, if we look at this next, based on the review, 10% found that they'd modify their treatment based on what they found in the outcomes. And I think to some of the things we've been saying about confidence and increasing your clinical knowledge and just trying to be the best clinician you can be, these outcomes can really help the next patient, right? And the one after that, if 10% are finding that they'd modify their treatment in some way. Now, you'd always want to go back and you find these little nuggets and say, well, how big of a modification are we talking about, right? But that 10% is a really interesting finding. But overwhelmingly, right, 84% said that they'd provide the same treatment, which I think should be encouraging to our educators and our field training officers out there, that folks are they're doing the right things for our patients. And then there's always more information needed. We want more information on this table, right? There's more information always needed. So we have about 6% there. When we talk about agreement or disagreement with the use of outcomes to reinforce their clinical knowledge, again, if we combine the agree and strongly agree, we're up in the high 90%. And it's similar as we go down when we talk about for quality of care provided. And if you, what was interesting is this last question here is basically asking, if you got more of these opportunities, would you continue to utilize them? And again, overwhelmingly agree or strongly agree, with the two there who said absolutely not, strongly disagree. But overwhelmingly, most folks said that if you provide these opportunities, we will use them. And there, with some of the, when you contextualize this with some of the other results we just talked about, this could really have a positive impact.
So then what are the questions that this leads you to? Looking at this, what do you say then? Okay, if the responders are saying they strongly agree that they agree or strongly agree that this improves my outcomes, it's actually just as important to say I would provide the same treatment because it reinforces my practice as I would modify my treatment. What kind of questions does this take you to? Like, oh, it would be great to know this in the next research study. I'll open up to all of you, everybody. Yeah,
why don't we?
Go ahead,
Michael,
Tony.
I was going to say, go for it, Tony.
Yeah.
I was going to say too, like, imagine every other CE class you take. Do you think 98% of people would say this helps make me a better provider? Right. Like,
good point.
Maybe if you're listening to the Scott Bourne airway lecture, you might say that, or the Dave Page cardiology lecture. But most of the CE we probably sit in, I'd be thrilled if 50% of the people in my class were as excited about it as what we can get here for outcomes. So as we're thinking about how this drives practice into the future, this is one of the things I think this asks more questions about. People clearly want to do it. We've mentioned in the chat several of the challenges that overcome, but I'd love to get us to a point, and this again will do providers care, where we can break down the CE as micro learning for the specific condition. So, okay, you reviewed the outcomes for your last 10 chest pain patients, and you met whatever benchmarks we pre-established. You gave aspirin, you got the 12 lead, you took them to a cath lab, right? You don't need to do any more CE on cardiac patients because you've done what we've asked of you. that would be great. The other place I would take it is you could take it in the opposite direction. Say like, you failed to get a 12 lead on all of your chest pain patients. What are you doing wrong? And here's some CE for it. Like, you do need to go take this CE, because then it is that continued professional development concept that is user specific. So I think there's some opportunities there. It can go in, I much more focus on the positive direction, which is like, hey, you did great on all of your last stroke calls. Here's a CE module for 20 minutes on the NIH stroke scale. Because you're so good at stroke, we want to take it to the next level. Here's the next thing on stroke that's coming your way. That's where I would love to see it go. We've got a lot of
love
research to
that.
get it there.
I would 100% agree that we can upskill or credential or special credential or give special recognition to people who are particularly gifted, talented clinicians, so that they get credit for doing amazing things. I mean, this is the future. I can't thank you enough for doing this project and for actually bringing this to reality. I think when you look at some of the stuff that was done by Gordon Graham with the California Highway Patrol, you want to understand that Dave Page has not run a pediatric cardiac arrest for the last 2 years, and understanding that because I haven't done that, maybe that's what my continuing education should focus on, not the 1,500 STEMIs that I've been able to interpret and send, and that's not what I need. So one size doesn't fit all, and this endless, I'm going to teach you how to read a P wave in my continuing education does not help me with some of the things that I don't know. It's also striking to me, and a shout out, I don't have a conflict of interest. I'm going to just give a shout out to ESO, Image Trend also, but ESO in particular, for having supported the PCRF and in the workshops, and discovered things that I thought, like, really, does that matter? Does that really happening? The paper on atrial fibrillation and actually giving diltiazem or giving antibiotics to open fractures. When we find out the outcomes of these patients and we find out that they actually had sepsis from an open fracture, it might actually cause us to think, oh, we should be carrying antibiotics because that's a American Academy of Orthopedic Surgeons recommendation. We don't know that until we look at the punchline. And this automation into what happened to my patient is, I think, the game changer. So keep doing what you're doing.
I'm curious about initial education as well. So pre-licensure, pre-certification education, because you mentioned that in the very beginning, you talk about integrating into curriculum. And I'd love to hear more about that. If this goes from the day you walk into class and you start doing clinical rotations and you start to, I mean, that is the value, perceived at least, value of clinical hospital rotations, rather than just training in the field. And that is that to, learn more about the outcomes.
I think it probably already is, just like we have these sort of ways, and we found this in our studies, right? Like, there's actually paramedics have figured out the ways to figure out what happens to their patient if they don't have a structured system to do it. My EMT and paramedic students do it all the time. Hey, we had that patient in the ER. I was in the ICU the next day, and so got to see them. And so we're connecting the dots on what their continuum of care was. Or we had a student see him in the pre-hospital setting. We had a student see him in the ED. We had a student see him in the operating room. And they talk about it. So we should do this study there too. But I think there's this intuitive nature that people want this, even in the initial education, just based on what we've seen. So yeah, it's definitely that need is there.
But I'll also go back to Megan's question. I think the need is there, and a lot of people are trying to glue those things together. But I think we have to, again, going back to the education nerd side of me, what we're talking about here is creating a reflective practice. And I think we need to talk about it as such, so that when I'm in initial training, I learn that part of my job as a evolving clinician is to reflect on practice. And here are sources of information from whence I can gain feedback on that patient. Which means when we start doing, simulations in the lab or those kinds of things, that we wait till they're done with the simulation and then say, well, here's the diagnosis. And it has to be legit. We can't make stuff up. And then from there say, so let's talk about how do you feel now that you know this is what you thought it was and this is what it is. There's a lot of good literature available on creating a reflective practice, and this is a tool to get there. So I think we start that in initial education, in my mind, so that people know what to do with this information and how to grow with it.
Wow. And I know that that speaks to a lot of what we talk about here. Kim McKenna in particular reflecting on your practice. So I couldn't agree more. The other
It's
thing,
my turn. It's my turn now. You
oh, go
don't see
ahead,
me,
Bill.
Megan.
No, I can't because there's only so many squares that appear, and guess what? Your square wasn't appearing.
That's
Jump in
right.
there.
Go, Bill.
So I tried to jump in earlier, so I just want to backtrack on something that we talked about when we talked about exchange of patient information, and that in some cases, the vendors of EPCRs may help us in that. But what I really think we need to consider or think about is getting our large professional organizations to be putting position papers out and sending them to the American Hospital Associations, to the people that can get the exchanges. So no matter whether it be state EMS directors, EMS physicians, the NAMT, any of those organizations need to gather that and say, we need this connectivity to be more seamless, and vendors have the ability to help create that seamlessness. And that's something I just wanted to touch on the back. And then what you were just talking about here at the end, I think is very important, particularly when you talk about what I like the idea is you're customizing the CE to the provider, because we all know we've sat in the meeting and the chief of the department goes, okay, only one of you is the problem, but I want you all to know this, and then the people that aren't the problem are sitting there and saying, why am I being yelled at for something I have absolutely nothing to do with? And that's the same way I think about CME. Yes, I am very competent in this area. And, for example, what I choose to do, my renewal is I take the registry exam every 2 years. I just do that as my renewal. And it will let me know as I'm taking it, it says, ooh, I need to go back and work on this a little bit. I can tell right why I'm even taking the exam, where I says, I have no clue what this is. And I'm guessing at it, but I know the topic area. And then the final thing on it is that it is great to give people a prescription to follow, whether it be, please watch this video or do this. But if the material is junk, the people will just turn it on. And when it's done, they can click the box. And we need to get our continuing education away from just trying to get it done, so it is meaningful and it does impact patient care. And it's growing. I do believe there's value in looking at old, truly refreshing something that is, low frequency, high criticality. But I also believe there's that opportunity to grow, and that's going to depend upon the individual, because we're all going to grow at different paces and stuff. But I want to thank the authors for the work on this paper, because I know we're coming to the end here. And I just think it was really good. I really enjoyed it. I appreciate your work. I appreciate you sharing the time with us. That's just so important.
Thanks.
I just want to quickly say that there is a draft. It's coming close to the conclusion of a continued competency agenda for the future that talks about activities just like what you all studied here. So thank you so much for that. I think the EMS community is ready for better opportunities for continuing education, or more diverse opportunities is probably a better way of saying that. So thank you.
Absolutely. And before Megan transitions us to the next podcast, I think on behalf of all of the authors, thank you so much for all those people that took the surveys. Again, we sent this out to over 800 people. They watched videos. They dealt with the logistics of what Medicare and ICD-10 codes are. So I personally want to thank the authors for working together on this great project. We're so excited that it's out, but also the survey participants that took their time out of their day to take our pre and our post survey and the CE process. So we owe them a great debt of gratitude as well.
Great. Thank you all. If anyone has any final comments here, Speak now. But this, thank you all for this. I'm looking forward to more. Hopefully you are continuing this research and or even sparking some others out there who would like to carry the torch as well. This is really important, not just for continuing education, but for initial education as well. Thank you all for joining us. Remember, our next Education Research Journal Club, we will be back in a month on March 28th at 10 a.m. Pacific, noon Central. We're going to be talking about the effects of clinical practice stress coping, and empathy on clinical competency among paramedic students. This is actually a study that comes out of Korea. So our next clinical journal club, though, you can join us earlier with Dr. Tony Fernandez, Dr. Remley Crow, and others. And this will be on Monday, March 10th. Remember, you can join us live each month. You can register at prehospitalcare.org. And don't forget, you can catch the YouTube channel and subscribe and check out some of our prior episodes. So we will see you next month. Again, thank you all for joining us. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.